Hello guys, and welcome to the drug-drug interactions wherein we are going to focus more on the alteration and pharmacokinetic actions. And as we said earlier, pharmacokinetic interactions merely focuses on the concentration of the drug in the body, and the causality may be related to the pharmacokinetic actions of two interacting drugs in the system when taken concomitantly. Okay, so let's start. First, we go to alteration of gastrointestinal absorption. The organ for drug absorption is the small intestine, and it primarily be affected based on the nature of the medication on how it deals with our gastric pH and its physical characteristics. Or maybe it will also be affected by the rate of gastric motility or rate of gastric emptying, formation of complexes, or it may also alter the gastrointestinal flora or malabsorption. So let us move forward with alteration of gastric pH. But first, I want you to remember this and put this idea into your mind that an acidic drug is based or is best absorbed in the acidic environment, and the basic drugs will be best absorbed in the basic medium. Now, saan ba yung acidic environment na sinasabi ko? Definitely in the stomach because of the presence of gastric juices, or essentially our gastric acid or hydrochloric acid. Also, take note that basic drugs are absorbed in the small intestine, and for the basic drugs to reach the small intestine, it needs to surpass the powers of gastric acid. So it may be in the form of enteric coating or any kind of protection for the basic drugs to be protected from the acid of our gastric juices. Our first interaction is ketoconazole and cimetidine. Okay, ketoconazole, with the trade name of Nizoral, it functions by preventing the synthesis of ergosterol, which is essentially the equivalent of cholesterol. So basically, cholesterol is for humans, ergosterol is for the fungus. Now, what ketoconazole does is that it inhibits the synthesis of ergosterol, and low ergosterol is equals to increased fluidity. In the concept of phospholipid bilayer, di ba ang cells natin may hydrophobic heads yan. And meron din siyang hydrophilic tail in the other side. Meaning, ayaw nung head sa fluid kasi nga hydrophobic siya, and gusto ng tail yung fluid kasi nga hydrophilic siya. Now, ketoconazole increases the fluidity of the membrane, thereby preventing the growth of the fungus since altered na yung cellular response niya. One of the physical characteristics of ketoconazole is that it has a pKa of 2.9. Ano ba yung pKa? pKa is the measure of the strength of the acid. So meaning, if mababa yung value ng pKa mo, mas acidic yung compound mo. In this case, 2.9 is low. Therefore, acidic si ketoconazole. Saan ba dapat siya ma-absorb? As I have mentioned earlier, acidic drugs are best absorbed in, yes, tama, acidic medium. If ketoconazole is in an acidic environment, it is an ionized, which is actually best absorbed. Sa stomach, ano ba ang criteria natin for absorption? I will abbreviate this one as LUNA. So if the drug is lipophilic, letter L, it is an ionized, UN, it will be absorbed. A, LUNA, lipophilic, and ionized, absorbed. So, tandaan nyo yan, ha? Okay, moving forward, now if you have taken ketoconazole with cimetidine, which is essentially an antacid, it will alter the gastric pH, making it more basic or less acidic. So ang mangyayari, yung prevention ng synthesis ng ergosterol ng fungus, yung pag-increase ng membrane fluidity ng fungus ay maa-alter din because ketoconazole will be less absorbed. Now, question, cimetidine lang ba ang cimetidine lang ba ang may interaction kay ketoconazole? Definitely not, syempre. Any antacid or any compound that alters the gastric pH will definitely decrease the absorption of ketoconazole. Now, The best way for you to manage this type of situation is that you should adjust the dosing interval of these two medications and explain to the patient what will happen if they'll take it simultaneously. This is crucial, especially when you are already in the practice. You should always advise the patient on what to do and do not assume na alam na nila yung gagawin nila. So what are you going to do is to always and always and always remind them. Okay? Next, bisacodyl or bisacodyl plus antacid. Bisacodyl or dulcolax acts by producing colonic peristalsis in the colonic mucosa, meaning they promote peristalsis, or what do you mean by peristalsis? Peristalsis, ito yung series ng muscle contraction sa intestine natin to promote defecation or relieve constipation. Kasi nga, when we are constipated, we are actually taking bisacodyl for us to promote defecation. Then, as it was hydrolyzed by the intestinal borders enzyme or colonic bacteria present in our colon. So, bisacodyl is technically being hydrolyzed first before it acts as an anti-constipation. Now, one of the physical characteristics of bisacodyl is actually it is an enteric-coated tablet. It is in the form of enteric-coated tablet. Kasi dapat ma-absorb siya sa basic environment. So meaning, bisacodyl is a basic drug. Therefore, absorption should take place, or it should take place in the small intestine or in the large intestine, or sometimes any part of the intestine, as long as it is not being absorbed in the stomach. Now, what will happen if pinagsabay mong inumin si dulcolax and antacid? It will prematurely disintegrate bisacodyl. Yes, tama. Dapat kasi yung enteric coating niya, yung pangsangga niya sa acidic environment ng stomach. Now, if ma-alter yung pH ng gastric acid, mapapaaga yung disintegration ng or disintegration ng bisacodyl. Tapos ano ang after ng disintegration? Di ba? Dissolution. Tapos magiging ionized siya or wait. Dapat kapag ma-absorb siya, dapat magiging ionized siya. Pero since nga wala siya sa tamang pwesto niya, magiging ionized siya. Therefore, it will not reach the small intestine or the large intestine, and the resulting effect is it will decrease the absorption of bisacodyl or bisacodyl. Now, since hindi naman dapat ma-expose si bisacodyl sa stomach, but if that happens, gastrointestinal irritation will occur in the form of vomiting. And we don't want it to happen naman. Siyempre, constipated ka na nga, tapos makaka-experience ka pa ng vomiting, who would want that, di ba? So again, I would like you to do your part as a pharmacist to always and always remind your patients to not take them simultaneously. Okay? Next, pentobarbital plus antacid. Pentobarbital with the brand name of Nembutal is used for the treatment of short-term insomnia. Remember, acidic drug is equals to acidic environment. Absorption of drug, if it's acidic in a basic environment, it will not be absorbed. So let's stay in that context. So as I have mentioned earlier, pentobarbital is being used for the treatment of insomnia by inducing drowsiness and relieve tension or pampakalma or tatanggalin niya yung kaba mo. So, kapag gano'n ang mga actions kasi, tinatawag silang central nervous system depressants. And as we all know, pentobarbital is a derivative, meaning galing siya sa family ng mga barbituric acid. So, ayun na yung clue, acid, meaning acidic siya. What will happen if tinake mo siya with an antacid? It will decrease the absorption of pentobarbital. Thus, CNS depressant will also be delayed. So again, I would like you to advise your patient to do not concomitantly use pentobarbital and antacid and always adjust the dosing regimen of these two medications. So that's the last example for our alteration of gastric pH. Now we are done with the first part. Let us now move on with the another type of alteration, which is the alteration of motility or rate of gastric emptying. This is also under gastrointestinal absorption, ha? But before we move forward, what is rate of gastric emptying? Meaning, ano ba yung rate of gastric emptying? It is the measure on how long the food or any content will actually travel from your stomach, okay? The first station is stomach up until your small intestine. So any alterations in the gastric emptying rate will also have an effect in the absorption of our medication. So dapat kasi physiologically normal lang ang ating gastric emptying time, or else any alteration will cause decrease in absorption. Now let's move on with our first interaction, which is isoniazid plus aluminum salts. Isoniazid is also known as isonicotinic acid hydrazide. Kaya siya abbreviated as INH. Uulitin ko, isonicotinic acid hydrazide. Isoniazid is also a prodrug, meaning kailangan niya muna ng enzyme para ma-activate siya to produce something clinically effective. Now, once it is activated, it inhibits the synthesis of mycolic acids. Para saan ba itong mycolic acid nito? Mycolic acid is an essential component of bacterial cell wall, especially sa mga mycobacteria. So kung wala ang mycolic acids, ang cell wall ng ating mga mycobacteria ay magiging impaired, thus mabilis na lang natin itong ma-attack. Kasi nga isoniazid, may mga kasama pa yan, di ba? Isoniazid, pyrazinamide, in another form of drugs din. Siyempre, dapat magkakasama sila for it to produce a more clinically effective outcome. So, isoniazid is also best absorbed in the small intestine. Therefore, it is a basic drug. Now, what will happen if you take it with aluminum salt? Like, you take it with aluminum magnesium hydroxide, for example. Definitely, it decreases the GI motility. Therefore, the transit time of isoniazid going to small intestine, saan siya galing from stomach, going to small intestine will be delayed. Also, if it stayed too long in the stomach, it will be prematurely disintegrated. So kapag na prematurely disintegrated yung ating mga gamot, ano nangyayari? Normally, nagkakaroon tayo ng gastrointestinal irritation. Added idea. Okay, since na-mention naman na natin si aluminum salts, for you not to be confused, ha? And maybe this one will also be asked in your board exam. Always remember that magnesium is equals to constipation, aluminum is equals to constipation, okay? Magnesium is equals to diarrhea. So, nung ako yung nasa review center, ang mnemonic namin dito is aluminum ala-tae. Magnesium mag-tatae. So, remember these two. These are basic, but definitely or maybe lumabas sila sa board exam ninyo. Next example of drug interaction is cathartics and metaclopramide. These are the two types of, there are two types of cathartics, one of which is stimulant or irritant cathartics. Ano ba yung ginagawa ng mga ganitong type ng cathartics? It technically stimulates intestinal motility by irritating the mucosa or stimulating the nerve plexi. It also activates secretory mechanism, meaning cathartics will induce the secretion of fluids in the GI lumen. So meaning naglalabas siya ng or nagpo-promote siya ng pag-increase ng fluid sa lumen ng intestine natin. Example of which are Senna and Bisacodil. These two one here. If Senna and Bisacodil affect the large intestine and are found in many over-the-counter human laxative formulations. So meaning, pag gusto natin mag-defecate or we want to promote defecation, they are actually readily available sa mga community pharmacy natin. Another example is castor oil. Castor oil is hydrolyzed to release ricinoleic acid. So ano ba ang ginagawa ng ricinoleic acid pag na-release siya? It will cause increased water secretion in the small intestine, thus it will also increase the intestinal motility. Another type of cathartic is hyperosmotic cathartic in the form of magnesium salts and sodium salts. Example ng mga yan ay ang magnesium hydroxide, sodium biphosphate, or sodium phosphate enemas. They are actually not absorbed in the GI tract, but they will draw out fluid sa intestine natin. Therefore, ang fluid content ng feces natin mag-i-increase. Tapos lalambot siya. Pag lumambot siya, magkakaroon tayo ng intestinal distension. Ano nga ba yung intestinal distension? Mag-i-expand yung intestine natin. Pero syempre, since hindi yun yung actual form ng intestine natin, ang gagawin ng body natin, mag-i-increase siya or magpo-promote siya ng peristalsis para bumalik siya sa dati niyang form. Therefore, magkakaroon tayo ng defecation. So, as I have mentioned earlier, ang examples ng mga ito ay ang magnesium salt and sodium salt. Now, if there are different types of diarrhea, and one of them is osmotic diarrhea. Actually, ang osmotic diarrhea, same lang din ang mechanism niya dito. Water will not be absorbed properly by gastrointestinal tract, then it will stay sa intestine, thus promoting peristalsis, and it will result to diarrhea. Trust me, maririnig nyo ulit ang osmotic diarrhea, but ang concept lang nun, hindi na-absorb properly ang fluids, magkakaroon ng intestinal distension, magpapromote ng peristalsis, defecation. So, one example ng hyperosmotic cathartics natin is magnesium salt in the form of magnesium hydroxide. Magnesium hydroxides are frequently used orally saline purgatives. Di ba, ang palatandaan natin, magnesium magtatae. Normally, ang mga magnesium compounds natin, 20% lang ang systematically absorbed sa kanila. And the rest will be eliminated. If ang absorption ng magnesium is excessive o kaya naman renally impaired ang patient natin, severe hypermagnesemia or metabolic alkalosis may also develop. Sodium salts can also be given orally as saline cathartics, but are more commonly administered as sodium biphosphate or sodium phosphate enemas. This should not be used in cats. Why? Because it may cause hyperphosphatemia, which is fatal, hypocalcemia, and hyponatremia. So, ang mga enema nyo na may sodium compounds, you do not want them to use in your cats because you may not be able to see them on the other day kasi nga, iniwan na nila kayo. Now, ano ba ang kapartner ng interaction na to? Metaclopramide. Metaclopramide causes anti-emetic activity or anti-emetic effect by inhibiting dopamine D2 and serotonin receptors in the chemoreceptor trigger zone. In short, metaclopramide promotes rate of gastric emptying by means of decreasing the pressure of our lower sphincter. Ito, asan ba ang lower sphincter natin? Ito. Kasi ito pyloric sphincter na to, di ba? Ano ang mangyayari pag na-lessen ang pressure nitong lower esophageal sphincter natin? Di ba ang transit natin from stomach to intestine? So if lessen yung pressure niya, mas mabilis papasok yung contents or yung foods sa stomach natin or yung any xenobiotics like our drugs, mas mabilis din siya makakapunta dito sa small intestine, going there. So kapag, kasi ito talagang mataas ang pressure nito eh. Kasi kapag ang pressure nito hindi mataas, there are possibilities na magkakaroon tayo ng gastroesophageal reflux disease. So, mabalik yung mga acids natin. I'm sorry. So, babalik yung mga gastric acid natin if mababa ang pressure nito. So, ang ginagawa ng metaclopramide, pinapababa niya yung pressure nito para agad pumasok yung kung ano mang kinain natin or ininom natin gamot para sa transit time ng gamot natin. Now, sa dinami-dami na diniscuss natin, ano bang mangyayari pag pinagsabay mo si cathartic and metaclopramide? Bababa ang action ng cathartic. Okay. Why? Because agad silang papasok sa stomach natin, mapapabilis yung transit time niya, hindi pa siya fully disintegrated, nakarating na siya dun sa dapat niyang puntahan, meaning yung promotion ng defecation mo, malilesen din. So if you are constipated or undergoing radiologic exam that needs to cleanse your bowel first before going to the procedure, do not take metaclopramide if you are also taking cathartics. Next is anticholinergics. Ipratropium, scopolamine, tiotropium, and hyoscyamine are examples of anticholinergic drugs. Ano bang ginagawa ng mga anticholinergic drugs natin? It will decrease gastrointestinal motility, but it will increase or decrease absorption depending on the medication you are taking. Example, drug A plus anticholinergic. If your drug A is acidic and you combine it with anticholinergics, so drug A, for example, this drug A is acidic, tapos kinumbine natin siya sa anticholinergic drugs natin, in the stomach, basically, if the drug is acidic and it stayed in the acidic medium, technically, ano mangyayari? Mag-i-increase ang absorption kasi nga acidic siya, acidic drugs, acidic environment. But, for example, drug B. Ang drug B mo ay basic, tapos sinabay mo siya sa anticholinergic mo. In the stomach, if it stayed too long in the stomach and it is a basic drug, then there will be a premature disintegration. Thus, it will not reach the small intestine where it is intended to be absorbed. So, magkakaroon lang tayo ng gastric irritation, magkakaroon tayo ng vomiting kasi nga hindi siya nakapunta ng small intestine, nag-disintegrate siya na maaga. Now, in the small intestine naman, so tapos na tayo sa stomach, in the small intestine, if drug B was ang drug B kasabay na sa anticholinergic, in the small intestine, it will be delayed. The absorption actually is being delayed. Why? If the drug is enteric coated, for example, there will be a delay in absorption to reduce absorption of the drug since normal peristalsis or gastric motility is impaired. So, impaired na yung gastric motility mo. Ito Kasi ang sabi niya, anticholinergics decreases gastrointestinal motility. So in the small intestine, hindi siya agad makakadating doon sa small intestine kasi nga ang gastrointestinal motility mo nag-decrease na, so mas matatagalan ang biyahe niya. Kumbaga, na-traffic siya, parang ganun. So, I think that's all for the alteration of gastric pH and alteration of gastric motility. I hope to see you in the next video to discuss complexation, alteration of GI flora, and malabsorption. These are the next lessons that we are going to tackle. So for now, thank you for listening and thank you for your attention.